Hello everyone, I am myself Dr. Rajesh Gubba. I am the general medicine educator. So in this session, I'll be trying to discuss the FMGE recall questions of December 2021. So before starting the session itself, let me tell you the questions and options may be wrong because as they are purely the recall questions from the students. So for some questions, they just faintly remember the options, and for some questions they directly said the images, sir, this is the image which has come. So in some questions I'll be directly showing you the answers. In some questions I'll be showing you just only a single liner questions and the respective answer. Okay, right. So let us start with the session. So this was one of the ECG asked in your exam. So in this ECG, I'll just point out what exactly are the abnormalities. So you can observe that there is ST segment elevation in lead 2, lead 3 and as well as the AVF. So ST segment elevation in 2, 3 AVF. What is this suggestive of? This is suggestive of the inferior wall MI. And some of the students said, sir, it was anterior wall MI. Now let me tell you what exactly will be the difference in the ECGs between the inferior wall MI and as well as the anterior wall MI. In inferior wall MI, it is lead 2-3 AVF, there will be ST segment elevation and the patient will present with acute onset chest pain. And these patients with inferior wall MI, they can also have hypotension. And for those students who said it's an anterior wall MI, let me show you the ECG of the anterior wall MI as well. So in case of anterior wall MI, you will have ST segment elevation in lead V1 to V4, right? So whatever is the question which has appeared in the exam, you just try to make out from these two, whether it is an inferior wall MI or whether it is an anterior wall MI. I have shown you the ECGs of both. Now, after having said this, there was one more question. So some said this is the image, but some others said the other way around. I'll show you both the images. Okay, but anyways, if this was the image, then let me tell you the answer is the WPW syndrome, that is Wolff-Parkinson's-White syndrome, which is a pre-excitation syndrome, right? And in this pre-excitation syndrome, the accessory bundle is the bundle of Kent. And what will be the ECG changes in this particular image and as well as this type of ECG strip? So we have the two important abnormalities that you can make out. One is the presence of the short PR interval, right? The PR interval will be less than 120 milliseconds, right? And other abnormality that you will observe is the presence of the delta wave. Okay, so you can see the QRS complex. So, and within the QRS complex, so you can make out this is your delta wave, okay, which is nothing but the slurring of the upward slope of the QRS complex, that is called delta wave. But some students said, sir, this was not at all there, WPW syndrome was not at all there, and the ECG was suggestive of the sinus arrhythmia, right? And this is the ECG suggestive of sinus arrhythmia. Now, what is this ECG of sinus arrhythmia? Let me discuss. Right, what is the ECG suggestive of sinus arrhythmia? Let me discuss. Sinus arrhythmia, it is a normal physiological phenomenon and it is most commonly seen in young healthy people. And what will be the ECG changes in sinus arrhythmia? The heart rate, it varies due to reflex changes in the vagal tone during different stages of the respiratory cycle. So you can observe at this point that the heart rate, it is increased. So let me tell you, during inspiration, there will be increase in the heart rate. Okay, so during inspiration, there will be increase in the heart rate. Next, and why there will be increase in heart rate? That is due to decrease in the vagal tone. Whereas during expiration, there will be decrease in the heart rate. And why is that there is decrease in heart rate during expiration? That is due to increase in the vagal tone, right? So that is due to increase in the vagal tone. So that is about the ECG suggestive of sinus arrhythmia. And let me tell you, it is a normal ECG which is seen in young healthy people, and it reflects the changes in the vagal tone. Okay, next. So I don't know whether which ECG has come, whether it is sinus arrhythmia ECG or WPW syndrome ECG, but I am discussing the both. And there was one more question, like tall T waves are seen in the hypokalemia, hyperkalemia, and then hypokalemia. Let me tell you, the presence of the tall T wave are seen in patients with the hyperkalemia. Tall T waves, you have two types of tall T waves. Like you have tall tented T waves. So tall tented T waves are seen in patients with hyperkalemia, whereas if you see the T wave here, it is tall, but it is broad, tall T wave. And this is seen in patients with acute MI. Right, this is seen in patients with acute MI. So this is about your broad, tall T wave. Okay, so here the answer is the hyperkalemia. And next question is, all of the following are obstructive lung diseases except. So students have directly given me the answer without telling the other options, but the answer is the interstitial lung fibrosis. Interstitial lung fibrosis, it is a restrictive lung disease, right? And what are the examples of obstructive lung diseases? That is asthma, then we have bronchitis, next is bronchiectasis, then COPD, and then cystic fibrosis. So these are all your obstructive lung diseases. So the other options could be any of these, and the one which is not an obstructive lung disease is the interstitial lung fibrosis. Next, the other question was, wide split S2 is heard in. The answer is the atrial septal defect. And let me tell you, the wide split S2 in ASD, it is wide fixed split. Right, it is a wide fixed split. What do you mean by the word fixed split? That means the split is present, right? The split is present both during inspiration and as well as the expiration. That is called as the fixed split, right? The split is present during inspiration and as well as expiration. That is called as wide fixed split. And this was the answer directly. And other conditions where you can have wide split S2 is, you can see that in VSD, mitral regurgitation, right? And in patients with the right bundle branch block. So these are all the other conditions where you will have wide split S2. Okay, next. Popcorn calcification in the lungs are seen in which clinical scenario, right? So the answer is the hamartoma. So you can see that here, this is the popcorn calcification that you can observe within the lungs. The answer is the hamartoma. And the next question was about the tissue plasminogen activator. What is the mechanism of action? Tissue plasminogen activator, it is used for fibrinolysis. What exactly the tissue plasminogen activator does is, it converts plasminogen to plasmin. Right, it converts plasminogen to plasmin, and it is the plasmin which will cause the fibrinolysis. So this is used as a fibrinolytic agent, used in the treatment of cerebrovascular accidents, that is ischemic infarcts, and the patient presenting to you within less than 4.5 hours, and also used in thrombolysis of the acute myocardial infarction. So that is about your tissue plasminogen activator. Then lymphogranuloma venereum is caused by. The answer which is given in your exam is the chlamydia trachomatis. That is the organism which will cause lymphogranuloma venereum. And there was one more question on the Meek syndrome. I don't know what exactly are the options, but let me discuss few points about the Meek syndrome which have been given in your options. So it is a triad of the pleural effusion, and this particular pleural effusion, it is mostly right-sided pleural effusion, ascites, and benign ovarian tumor. This is what is the triad in the Meek syndrome. And let me tell you what type of pleural effusion you will have this in Meek syndrome. You will have both exudative and as well as the transudative type of pleural effusion. But exudative type of pleural effusion, this is more common than compared to that of transudative type of pleural effusion. Okay, so this is the question which has been asked on the Meek syndrome. And there was one more clinical scenario which has been given. A woman with the past history of esophageal varices on endoscopy, now had hematemesis and suddenly died. What would be the cause of death? The answer among the options which has been given to you is the hypovolemic shock, right? Because of excessive increase in the pressure within the esophageal varices, this might have ruptured, causing severe hematemesis, making the individual to land up in hypovolemic shock and death. Next, there was one more question on the Mucor Mycosis. Mucor Mycosis is most commonly associated with, Mucor Mycosis, the fungal infection. The fungal infections, they are commonly associated with diabetes mellitus, or it is associated in individuals who are immunocompromised. And that immunocompromisation, it would be either HIV or the patient on steroid therapy. But the answer among the options which have been given to you is the diabetic ketoacidosis, right? Most commonly associated with diabetic ketoacidosis. Now, one more question was asked. What is the most common type of the renal stone? Calcium oxalate stone, citrate stones, uric acid stones. The answer to the question is calcium oxalate stones. That is the most common type of the renal stone. And there was one more question asked from the topic of the head injury. That is, lucid interval is seen in subdural hemorrhage, extradural hemorrhage, subarachnoid hemorrhage, intraparenchymal hemorrhage. And let me tell you, this particular lucid interval, it is seen in case of the epidural hemorrhage. Right, it is seen in the epidural hemorrhage. And what is this lucid interval? So epidural hemorrhage is nothing but your extradural hemorrhage. And what is this lucid interval? Lucid interval, it is a temporary improvement in patient's condition after a traumatic brain injury, after which the condition deteriorates. Now, what will be the features during the condition when the individual is deteriorating? Like headache, confusion, somnolence, seizures and focal deficit occur several hours after the injury, and that may make the individual to land up even in coma. There can be development of respiratory depression and death unless treated by surgical evacuation. So, in acute epidural hemorrhage, you will have the presence of the lucid interval. Now, and there was one more question asked on the Menkes disease. Menkes disease, it is due to defect in the copper absorption. That is, there is copper deficiency. And in these patients with Menkes, that affects the copper level in the body is characterized by a sparse, kinky hair. Right? A sparse, kinky hair. And in these individuals, there is failure to gain weight. Right? There is failure to gain weight, and there is deterioration of the nervous system as well. Right? There is deterioration of the nervous system as well. So this is about your Menkes disease, right? Where there is deficiency of the copper. Next, one more question asked about the Cobra Venom. What is this Cobra Venom? Is it neurotoxic? Is it vasculotoxic? Or is it hematotoxic or myotoxic? Let me tell you, the Cobra Venom, it is neurotoxic. Right? Next. Now, yes, this is another very important question. In which type of vitamin deficiency you will have this atrophic glossitis or you'll have the tongue in this particular form. You'll have this in vitamin B12 deficiency. Regarding vitamin B12 deficiency or vitamin B12 related questions, you had almost 2 or 3 questions in the exam. Okay, and one among that is this image based question on the atrophic glossitis. And let me tell you, even certain other vitamin deficiencies can also cause the glossitis. That includes riboflavin deficiency and as well as the nicotinic acid deficiency. But the glossitis that you see in riboflavin deficiency and nicotinic acid deficiency, they occur along with angular stomatitis, right? So that is about the image which has been given about the tongue. Yes. Now another important image which has been given to you is the cannonball appearance is seen in. Cannonball appearance, right? So you can see that multiple white patches in more or less round shape in bilateral lung fields. Where do you see that? That you see in metastasis. Now, which particular malignancies can metastasize to the lung causing the cannonball appearance, right? So you can see this cannonball appearance in patients with, right, in patients with the renal cell carcinoma, also seen in patients with the choriocarcinoma. These two are very common, but can also be seen with prostate carcinoma, endometrial carcinoma, adrenal carcinoma, and as well as the synovial carcinoma. So in all these malignancies, there can be metastasis to the lung causing the cannonball lung metastasis, right? Next, another important question asked in your exam was about the Trotters Triad. So 3 components of Trotters include the deafness. And remember this particular deafness, it is the unilateral deafness. And there will be trigeminal neuralgia and defective mobility of the soft palate. Right, there will be ipsilateral soft palsy, and due to which there will be defective mobility of the soft palate. Now, what is the cause of this Trotters Triad? It is caused by malignant tumors involving the lateral pharyngeal recesses. Right, malignant tumors involving the lateral pharyngeal recess. Right, lateral pharyngeal recess. That is called as the Trotters Triad. And one more question asked was about the battle sign. So battle sign, you can see that here, this is your battle sign, and which clinical scenario you will come across this battle sign. So battle sign, it is basically defined as the bruising, right? It is basically defined as bruising over the mastoid process. That is called as the battle sign. And it is retroauricular or mastoid ecchymosis that is typically the result of the head trauma. That is about the battle sign. And this battle sign, it takes at least 1 day to appear after the initial traumatic basilar skull fracture, right? After the head injury, that is after basilar skull fracture, it will take almost 1 day to appear this battle sign. Next, another question was, yes, uncontrollable or excessive sexual desire in a man. The terminology what is given to that is Satiriasis, right? So I did not get the other options, but directly the answer was Satiriasis. But the same uncontrollable or excessive sexual desire in a woman, right? In a woman, that is called as nymphomania. Right, that is called as nymphomania, right? And another important question which has been given to you was about the cherry red spot. Cherry red spot, right? There was some clinical scenario about the treatment and all, right? The answer in the options given to you is the central retinal artery occlusion. But let me tell you, this cherry red spot on retina is not just seen only in CRAO. You have a mnemonic for that. The mnemonic is cherry trees never grow tall. C stands for central retinal artery occlusion. T is Tay-Sachs disease. N is Niemann-Pick's disease. G is Gaucher's disease. T is your trauma, right, which is nothing but the Berlin's edema. So the one which will cause the cherry red spot on retina, all these are the clinical conditions. Next. Now, one more important question is, they have given you the image actually. The clinical scenario is like the patient describing the worst headache in the life. And the answer is subarachnoid hemorrhage. And you can see the presence of the hemorrhage in the sylvian fissure. Right, that is in the subarachnoid space. And what is the most common cause of subarachnoid hemorrhage? Most common cause of subarachnoid hemorrhage is the head trauma. And second most common cause of subarachnoid hemorrhage is rupture of the berry aneurysm. So these are the important points about the subarachnoid hemorrhage. And one more image has been given to you showing multiple punched out lesions within the skull. And what is the diagnosis was the question. And the answer among the options given to you is multiple myeloma. Right? So multiple myeloma, which is a tumor of the plasma cells. Right? Where you have the presence of multiple punched out lesions within the skull. Next. There's one more question asked, drug to be given for cerebral edema. And the answer among the options given to you is manitol. And this particular manitol, it is an osmotic diuretic. And what are the other drugs apart from manitol that you can give to reduce the raised intracranial pressure? And those other drugs include, number one, manitol, loop diuretics, steroids, barbiturates, and as well as the anti-seizure drugs. So this is about the drugs. But the answer among the options given to you is the manitol. Right. And one more question asked was, they have given you this image, and this we call it as the slapped cheek appearance. And what is the diagnosis? The diagnosis is erythema infectiosum, which is also called the fifth disease. And it is caused by parvovirus B19. This is what is your slapped cheek appearance. Okay. Next. And another important question asked was, what is the drug that you will give for the treatment of the mountain sickness? And the answer among the options given to you is the acetazolamide. And if you see the other medications which are given for high altitude sickness, that includes number one, acetazolamide, which is a carbonic anhydrase inhibitor. Then we have dexamethasone, and you need to give oxygen and maintain the saturation more than 90%. Nifedipine, which is a calcium channel blocker, and hyperbaric oxygen, which will improve the hypoxemia. So these are the medications that are given for high altitude sickness, right? And the answer among the options given to you is the acetazolamide. And one more question was asked about the hypersensitivity reaction. What type of hypersensitivity reaction is RH incompatibility? 1, 2, 3, 4 hypersensitivity reaction. Let me tell you, RH incompatibility is the one which will cause the hemolytic anemia or hemolytic reactions, which is a type 2 hypersensitivity reaction. So, if you see all the types of the hypersensitivity reactions, so please remember this mnemonic, that is the acid. A stands for allergic associated hypersensitivity reaction. C is your cytotoxic. I is the immune complex mediated. D is delayed hypersensitivity reaction. So if you take type 1, it is IgE mediated reactions quickly after the exposure, and it is associated with allergens. Whereas type 2, it is the hemolytic reactions, Goodpasture syndrome, and then hyperacute graft rejection. Type 3, it is hypersensitivity pneumonitis, SLE, polyarthritis nodosa and serum sickness. Type 4, chronic graft rejection, purified protein derivative reactions, that is the tuberculin test. These are all your type 4 hypersensitivity reactions, right? And the question was asked is on the hemolytic reactions. Next, there was one more scenario like this. A patient after hip surgery post-op, he developed sudden onset shortness of breath and chest pain. What is the likely cause? So this clinical scenario was like this, okay? I don't exactly say these were the terms given, but the answer is the venous thromboembolism. So venous thromboembolism, it is most common after post-op, where the individual is bedridden for longer duration, where there can be stasis of the blood within the veins of the lower limb, and that will cause the DVT, deep vein thrombosis, and that can shower an emboli causing venous thromboembolism, due to which the individual can have sudden onset shortness of breath and chest pain. And if the question is asked, what is the most common site of DVT? Right? The most common site of DVT is in the distal veins. But what is the most common source of pulmonary embolism? Right? Most common source of pulmonary embolism will be the iliac veins, right? Or the femoral veins. Most common source for pulmonary embolism will be the iliac veins or the femoral veins. Okay. Next, there was one more question like this, showing you an image which is suggestive of the Brown-Sequard syndrome. So Brown-Sequard syndrome, it is the disorder where the individual will have the hemisection of the spinal cord. Right, where the individual will have the hemisection of the spinal cord. That is nothing but your Brown-Sequard syndrome. And in these patients with the Brown-Sequard syndrome, let me tell you, wherever is the site of lesion, right, that is which that particular half, for example, you consider in this image, it is the right half of the spinal cord which has been cut. So you will have the loss of corticospinal tract activity, loss of posterior column sensation, and contralateral there will be loss of spinothalamic tract sensations. Right? Contralateral there will be loss of spinothalamic tract sensations. So on the opposite half there will be loss of pain, temperature and as well as the touch. Whereas ipsilaterally there will be loss of motor function, vibration, position sense and as well as the fine touch. So that is about the Brown-Sequard syndrome. Next. And there was one more image asked about the areas of the auscultation. Right? And if you take the aortic area, it is present in second right intercostal space adjacent to the sternum. Pulmonary area, this is also present in the second left intercostal space adjacent to the sternum. That will be your pulmonic area or pulmonary area. Then if you take the Erb's point, that is present in third left intercostal space adjacent to the sternum. And tricuspid area, it is present in fourth left intercostal space adjacent to the sternum. Whereas mitral area, it corresponds to the apex of the heart. So these are about the areas of auscultation. And let me tell you one more area here, which we call it as, right, which we call it as the Gibson's area. So Gibson's area, it is present in first left intercostal space adjacent to the sternum. And this Gibson's area is used to auscultate the Gibson's murmur. And where will you see that Gibson's murmur? In patients with PDA, that is patent ductus arteriosus. Next, there was one more image asked for showing vegetarian with hypersegmented neutrophils. Right, so this is the hypersegmented neutrophils, and where is that you will have that in patients with vitamin B12 deficiency. So in order to count the segments of the neutrophil, we have a count called as ornith count, or which is also called ornith index. So ornith count or ornith index describes the nucleus of the WBC called neutrophil in attempt to detect the disease. Remember, older neutrophils, they have more lobes than compared to that of the younger neutrophils. And ornith count determines the percentage of the neutrophils with 1, 2, 3, 4 and 5 or more lobes. So that is about the ornith count, right? And yes, see, there was one more recall saying like slapped cheek appearance, that is your fifth disease, or your parvovirus B19. And one more recall was like malar rash in the children, and what is the most specific antibody, right? Whichever is given, that will be the answer. Either anti-Smith or anti-dsDNA. But in between these two, which is more specific? Anti-Smith will be more specific than compared to that of the anti-dsDNA. So that is about the antibody in SLE. Most specific, if it is asked, anti-Smith. For example, if the question is asked like most sensitive, then the answer will be anti-nuclear antibody. Right, the answer will be anti-nuclear antibody. Then, followed by that, yes, the question was on the hereditary hemochromatosis. What is the gene which is being mutated in hereditary hemochromatosis? So, the gene which code for the protein HFE, right? The gene which codes for the protein HFE will get mutated, right? So it is HFE gene mutation. And what exactly are the genes which are being mutated is C282Y mutation, then H63D mutation. But this C282Y mutation, this is more common. Right, this is more common, and this HFE gene, it is present on the short arm of the chromosome 6. Right, it is present on short arm of chromosome 6. And if you take the clinical manifestations in hemochromatosis, liver, it is usually the first organ that is being affected. And skin, if you see, there will be bronzing of the skin. And in pancreas, due to destruction of the beta cells, the individual will develop type 1 diabetes mellitus. And the joints which are being affected commonly is second and third metacarpophalangeal joints. And in the heart, in hemochromatosis, there can be development of restrictive cardiomyopathy and dilated cardiomyopathy. And there can be accumulation of iron within the gonads causing the hypogonadism. So this will be multi-system involvement in patients with the hemochromatosis. And the gene which is being mutated is HFE gene mutation. Next, the other question is 12-year-old child with history of cola colored urine and history of sore throat 2 weeks back. What is the diagnosis? So the diagnosis is post streptococcal glomerulonephritis, which is nothing but the nephritic syndrome. See, a patient presenting with hematuria with past history of infection, the flowchart is in the following manner. See, the patient presenting with cola colored urine, and this individual had infection 2 days back, right? Within 2 days of infection, the individual has the hematuria, early hematuria, and here the diagnosis is the IgA nephropathy. But whereas if the individual has the delayed hematuria, that is after 1 week of infection, you need to make out whether the individual has only renal manifestations or whether the individual is also having systemic manifestations. If the individual is having only renal manifestations, that will be post-streptococcal glomerulonephritis, right? See, our patient had history of sore throat almost like 2 weeks back. That is, it is like after 1 week of infection. It can be any time. It may be 2 weeks, 1.5 weeks, or anything. And if the individual is also having systemic symptoms along with hematuria, What will be that systemic symptoms? That include skin rash, arthralgia, abdominal pain, nephritis. So in this scenario, right, in this scenario you need to consider the Henon-Schollen's purpura, right? You need to consider Henon-Schollen's purpura. Next, now you see this question. Person taking platinum based chemotherapy, what is the drug which is used for preventing nausea and vomiting? The answer is palanosatron. That will be the drug used to prevent nausea and vomiting secondary to platinum based chemotherapy. Right. And there was one clinical scenario in your exam in the following manner. A 45-year male patient who is a non-smoker, who is a smoker, right, who is a smoker, presented with intermittent pain in the legs, and the pain is increasing on movement and decreasing on taking rest. What is the diagnosis? So it is nothing but thromboangiitis obliterans, which is nothing but the Berger's disease. So which is a medium vessel vasculitis, right, which is medium vessel vasculitis. So whatever is the history which has been given to you is nothing but the intermittent claudication, and that too with the background history of the patient being a smoker. That is nothing but your Berger's disease. And one more question was asked on congenital muscular dystrophy. That is, where is that you will have dystrophin gene mutation? Let me tell you, it is seen in two forms of congenital muscular dystrophies. One is Duchenne's muscular dystrophy and the other one is Becker's muscular dystrophy. But the answer among the options given to you is the Duchenne's muscular dystrophy. And so these are all the examples of congenital muscular dystrophies: Duchenne's, Becker's, limb girdle muscular dystrophy, Emery-Dreifuss, myotonic dystrophy, facioscapulohumeral, and then the oculopharyngeal. In Duchenne's, it is dystrophin gene mutation. Even Becker's, it is dystrophin. Whereas in limb girdle, it is myotilin, laminin, caveolin, caplane, and dysferlin. Whereas in Emery-Dreifuss, it is emerin and as well as laminin. In myotonic dystrophy, it is DM1 and DM2. In facioscapulohumeral, it is deletion of distal 4q. Oculopharyngeal, it is expansion of poly-A-RNA binding protein. So these are all the causes for congenital muscular dystrophies, and out of which the answer among the options given to you is Duchenne's muscular dystrophy, right? And one more question is on the occupational lung diseases. 40-year male patient presented with history of cough and expectoration. He works in a stone cutting industry. No doubt the answer will be silicosis, right? The answer will be silicosis. Okay, right. And one more question was like this: which anemia is seen after post-ileal resection? That is the megaloblastic anemia. And why is that? Because ileum is the site where you have the absorption of the vitamin B12. So if vitamin B12 deficiency is there, the individual will develop megaloblastic anemia, and along with that there will be also neurological manifestations. Okay, and that neurological manifestations will be in the form of subacute combined degeneration of the spinal cord. There can be development of the peripheral neuropathy. Okay, next. Right, so there was one more question like this. The patient is having thymic hypoplasia, then cardiovascular abnormalities, T cell defect, chromosome 22q11 deletion. And the answer in this question is Digeod syndrome. Now, what are the components of the Digeod syndrome? Digeod syndrome, let me tell you, this is also one of the cause for the hypoparathyroidism. And this will be the mnemonic for the components of the Digeods. And what is that mnemonic? That is catch-22. C stands for congenital heart defects, that can be in the form of ventricular septal defect. A stands for abnormal feces. T is thymic hypoplasia, that is thymus is absent. C stands for cleft palate. H stands for hypocalcemia. And 22 stands for the abnormality is on chromosome number 22. So that is about your catch-22. Next, there was one question from the neurology, right? The students were unable to give the entire scenario, but they were saying, sir, person was getting tired by the end of the day, right? So where is that you will have in patients with the myasthenia gravis. So myasthenia gravis being an autoimmune disorder where you will have diurnal weakness. Early in the morning the individual will be fine, but as the day progresses the individual tiredness increases. And this particular autoimmune disease, let me tell you, it is due to the antibodies which are formed against NM receptor on postsynaptic nerve terminal. Right, on postsynaptic nerve terminal. Right, so that is about the pathophysiology in myasthenia gravis. And one question was like this: which anti-tubercular drug is contraindicated in pregnancy? Right, so the options were unable to recall, but let me tell you, these are the drugs, and one of this particular drug was there in your options. These three drugs are contraindicated in pregnancy. Basically, your aminoglycosides, they are contraindicated in pregnancy, like streptomycin, kanamycin, amikacin. These are contraindicated in pregnancy, whereas isoniazid, that is H, right, and as well as the ethambutol, rifampicin, then pyrazinamide. These drugs can be given in pregnancy, but in streptomycin, kanamycin, amikacin, they are contraindicated in pregnancy. And there was one question on COVID-19 lung pathology, right? So there was a clinical scenario or a single liner, I am not aware of it, but the answer to the question is the ground glass opacity, right? That is about your COVID-19 lung pathology. And one more question was a clinical scenario like dry cough is due to side effect of which drug? That is the AC inhibitor. It may not be the same. I am not able to make out the entire recall, but I am trying to just teach you, trying to tell you what was the gist, summary of the question. So dry cough is due to the side effect of which particular drug? That is due to AC inhibitor. And why is this particular dry cough secondary to the AC inhibitor? That is due to increase in the bradykinin levels. And this increased bradykinin will cause the dry cough, or it can also cause angioedema. That is another important adverse effect associated with the AC inhibitors. Next important question was about the gynecomastia associated with which particular drug, and the answer among the options given to you is spironolactone. Let me tell you a mnemonic of the drugs causing gynecomastia, right? The mnemonic is the discos. D stands for digoxin, I is your isoniazid, S is spironolactone, C is cimetidine, and O is the estrogens. So these are the drugs which will cause the gynecomastia. And the answer among the options given to you is the spironolactone. Next question is drug used in pregnancy induced hypertension. There are many drugs given for pregnancy induced hypertension, but the answer among the options given to you is the hydralazine. So if you see the list of drugs, these are all the drugs what we give for hypertension in pregnancy: methyldopa, labetalol, nifedipine, hydralazine, hydrochlorothiazide, and as well as the beta blockers. But in the recent days, most commonly used drug is labetalol. But the answer among the options given to you is your hydralazine, which is an arteriolar vasodilator. The next question was about the drug resistance of tuberculosis. Resistance to rifampicin, isoniazid, kanamycin, ciprofloxacin. What is this resistance called? This is called extreme resistance, or it is called extensively drug resistant tuberculosis. Right? Extensively drug resistant tuberculosis. That is called XDR-TB. Right? So if you see the resistance wise, we have monoresistance, that is resistance to a single drug. Polyresistance, resistance to more than one drug. Whereas MDR-TB, that is multi-drug resistant tuberculosis, it is defined as resistance to rifampicin and isoniazid, with or without resistance to other first-line anti-tubercular drugs. Whereas XDR tuberculosis is that which is defined as resistance to rifampicin, isoniazid, N of any fluoroquinolone and resistance to one or more of the following injectable anti-tubercular drugs, that is kanamycin, amikacin, and as well as the capreomycin. And in the options which has been given to you was kanamycin. And quinolone, what has been given to you in the options, in the question was ciprofloxacin, and that we call it as the extensively drug resistance tuberculosis. Then followed by that, there was one clinical scenario on the COPD. What is the drug to be added to a patient with COPD taking salmeterol but there is no improvement? So what is this salmeterol? Salmeterol, it is a long-acting beta agonist. Right? So in spite of taking a long-acting beta agonist, if the individual is still symptomatic, that is the point when we need to add even the corticosteroids. So in the treatment of COPD, you require anti-inflammatory agents and as well as the bronchodilators. And among the bronchodilators, the preferred bronchodilator in patients with COPD will be the anticholinergic drugs. Right, that will be the anticholinergic drugs. Then followed by that, gum bleeding is due to deficiency of which vitamin? Gum bleeding, let me tell you, it is due to deficiency of vitamin C. Right, it is due to deficiency of vitamin C. Next, what is the adverse effect of the orlistat? The answer among the options given to you is the flatulence. And what is this orlistat? Orlistat is the drug which is given in the obesity. For reducing the weight, we give this orlistat, and it is a lipase inhibitor, right? And what it will do, it will reduce the calorie intake in the individual. It is a lipase inhibitor. So because it's a lipase inhibitor, it will prevent the lipolysis of the fat and it will prevent the absorption of the fat from the human diet. Okay, so flatulence will be the adverse effect of the orlistat. And there was one question like this, and the question was showing the symptoms of hypothyroidism and what is the treatment. That will be levothyroxine, that is T4. We don't give T3, right? We give oral levothyroxine. And whereas if you take the intravenous formulations of T4 or T3, we give that in case of myxedema coma. In myxedema coma, we give intravenous formulations, whereas oral formulations we give in case of the chronic hypothyroidism. So these were some of the questions related to general medicine, right? I may not be able to complete all the questions which were asked because I did not get the recall, but whatever the recalls I got, I have tried to cover in a nutshell manner. And if there are any mistakes in the questions which I have said, please forgive me. And thank you very much.